Okay, today we're going to be learning about fluid and electrolyte imbalances, particularly sodium. So the first learning objective, it's going to be um, which type of hyponatremia is going to be associated with decreased effective arterial volume. So effective arterial volume is basically the blood volume that's circulating in your body's system, going to all the places in your body. And basically, the thing you got to know about this is that even though a patient might look like they have their fluid overloaded, the arterial circulation can actually be underfilled. So the body's not going to pick up on that. But so think about this as in like diseases such as heart failure. They cause retention of sodium and water in the body, and because the fluid isn't where it should be, it kind of unbalances the three spaces in your body for sodium and water, and this imbalance gets picked up by the kidneys when they sense the low perfusion. This then gets perceived the underfilling of your the low sodium gets picked up by the triggers in the RAS system and the antidiuretic hormone, and this will end up increasing water retention and diluting the sodium. This then will result in the main form of hyponatremia that's associated with effective arterial volume, which is known as hypervolemic hypotonic hyponatremia, which is consistent with high total body water and sodium, but the water gain is going to be more than the sodium gain. So in the three categories I mentioned, there's going to be more water than sodium. So the next learning objective is the chemical signals that decrease sodium reabsorption. Now, what signals tell the kidneys to stop reabsorbing sodium? The key signals that are being peptides that are being picked up are the natriuretic peptides, which is ANP, BNP, and CNP. They're released when the heart senses stretch and volume overload. These peptides, basically what they do is they increase the GFR by dilating the afferent arteriole and constricting the efferent arteriole, promoting sodium and water excretion. They also directly inhibit sodium transporters like ENaC, NKCC2, and the sodium potassium ATPase. And this all results in less sodium reabsorption and more natriuresis, which then helps you to relieve fluid overload. All right, learning objective number 3. So this is just asking for the normal serum sodium range in a human adult, and that's going to be about 135 to 145 milliequivalents per liter. So remember, sodium doesn't just reflect the sodium content. It's a marker for water to sodium ratio. Remember those three three areas of the body. So learning objective number 4 is going to be hyperglycemia causing hypertonic hyponatremia. So hyperglycemia is an example of hypertonic hyponatremia. And basically this is the mechanism of how it works. The glucose acts as an effective osmol it pulls the water from the intracellular space to the extracellular space. The shift then dilutes serum sodium, even though the total body sodium hasn't changed. And you'll see that hyponatremia with elevated plasma osmolarity. In like clinically speaking, you'll probably be seeing that. And for every 100 milligram per deciliter increase in glucose above normal, serum sodium is going to fall by about 1.6 milliequivalents per liter. Then learning objective 5, diabetes insipidus and hypernatremia. So in diabetes insipidus, the problem isn't sodium retention, it's going to be water loss. So whether it's the central or nephrogenic, or in other words, no antidiuretic hormone or antidiuretic hormone release, the kidney can't concentrate urine, basically. The patient is going to lose large volumes of urine, basically, and this will lead to a loss of water. The total body sodium stays roughly normal, but together body water drops. So does serum sodium will rise from that. And so that's why diabetes insipidus causes euvolemic or normal volume water loss and hypernatremia with polyuria, polydipsia, and sometimes hypernatremic neurologic symptoms. But yeah, that's kind of just the rundown on diabetes insipidus and hypernatremia. Basically, it causes you to lose a ton of water. That's the big thing for this one. All right, number 6 is going to be pseudohyponatremia. Okay, so pseudohyponatremia, in this case, the measured sodium, it looks low, but the plasma osmolarity is actually at a normal level. So this happens when the plasmas are too high, or very high actually. And this displaces the aqueous portion of the plasma. And since sodium resides in the aqueous space, or the aqueous phase, lab assays that assume normal plasma consumption underestimate sodium concentration. So the patient isn't going to be fully, or they're not going to be truly hyponatremic, as you'd say. They're tonically normal, pretty much. But yeah, that's what pseudo means. It's false hyponatremia. So just remember that. All right, learning objective 7, the symptoms of hyponatremia. So the main symptoms of hyponatremia are going to be mild nausea, malaise, and mild confusion. Some moderate symptoms are going to be headache, lethargy, and which is just feeling kind of bloated, and then restlessness. And then the severe ones are going to be seizures, comas, respiratory arrest, or even death in some cases. And looking at the severe ones, just always assess the neurologic status, just with the seizures, the comas, and this can help you identify like what these symptoms are coming from, which would be low sodium. All right, learning objective number 8 is going to be about hypervolemic hypernatremia. So hypervolemic hypernatremia is less common, but happens when sodium gain is more than water gain. So we can think of some causes, like giving too much hypertonic saline or sodium bicarbonate. Uh, total body sodium and water are both up, are going to be up in this case, but sodium rises disproportionately. And this will, of course, raise sodium, serum sodium. You'll often see signs of volume overload, like edema, weight gain, and hypertension in this case. But yeah, that's kind of what it means, like hyper volume, like increased volume, and then hypernatremia, which increased sodium. All right, number 9 is going to be going over diuretic-induced hyponatremia. So diuretics like thiazides, they're going to be a main cause of hypovolemic, hypotonic hyponatremia. And that's a big mouthful, but that you got to remember that it's all 3 of those specifically. These diuretics, thiazides, they cause renal sodium and water loss because they make you pee. But the kidney often retains water through the antidiuretic hormone stimulation, again with the RAS and again with the antidiuretic hormone. It keeps that up in the body. But the result is going to be a low state and low serum sodium. And kind of a clue to when this is happening. So the serum sodium, you're gonna look at it, and it's gonna probably be more than 30, or urine sodium, it's gonna be slightly more than 30. And this basically indicates that renal loss is rather extra, or it's not coming from in the body, it's coming from the diuretics. But yeah, that's what diuretic-induced hyponatremia means. Just the drugs that are making pee are making your sodium content low. And then for the last learning objective, high serum sodium, but with total body sodium. So lastly, we'll look at hypovolemic hypernatremia. So low body volume and the increase in sodium. So here we're going to see that if a patient has this, they're going to lose sodium and water. The losses, this basically means that they lose more water than sodium. They're going to lose. They're going to lose both they're going to lose both sodium and water, but they're going to lose more water than sodium. That means that the total body sodium is going to go down and the patient will be volume depleted. Again, hypovolemic. So you can kind of figure that out just from sounding. So hypo, low, and then volemic, volume. The serum sodium is elevated due to the disproportionate water loss. So if that's kind of what you're wondering, why it's going to be more water. Basically, the loss of water is going to increase the sodium is going to be due to that loss of water. So the causes for this could include osmotic diuresis, diarrhea, sweating, all things where you're just losing a ton of water, or they can be drug-induced like loop diuretics, and that's mainly when you're like taking it when you don't really need to, or you're taking them when you don't have a great amount of water intake. You're not drinking enough, basically. So basically the best way to treat this would probably be to just replace both water and sodium, but make sure that you prioritize the water because that's what you're losing mainly with hypovolemic hypernatremia. So that's kind of it for the sodium-based electrolyte, the sodium fluid imbalances. I hope you have found this helpful, and we'll see you tomorrow.